The honest, evidence-based answer to whether back pain can heal without surgery is yes. For the vast majority of people, including those with disc herniations and sciatica. But I want to give you a complete and genuinely useful answer rather than a reassuring one, because the details determine whether this applies to your specific situation. Let me walk you through what the research actually shows, what physiotherapy does during the natural recovery window, and where the genuine limits of conservative management lie. Starting with the most clinically relevant numbers, approximately 90% of all episodes of lower back pain, including acute disc herniation with sciatica producing radiating leg pain, resolve significantly or completely within 12 months without surgical intervention. This is not an optimistic outlier. It comes from multiple prospective cohort studies tracking real patients with imaging-confirmed disc herniations. That matters. These are not general lower back pain studies, but studies of MRI-confirmed disc herniations producing leg symptoms, the exact presentation most commonly given a surgical prognosis, and 90% of them resolve meaningfully without an operation. The biological basis for this recovery is well understood. A herniated disc consists of nuclear material, the soft inner gel of the disc, that has been extruded through a tear in the outer fibrous ring and is pressing against a nerve root. Over time, this extruded material undergoes dehydration and is resorbed by the body's immune and inflammatory processes. MRI follow-up studies on unoperated patients with confirmed herniations regularly document significant or complete resorption of the herniated material within 6 to 12 months. Counterintuitively, the largest herniations, the sequestrated fragments that have broken completely free of the disc, tend to resorb most thoroughly because the immune system responds more aggressively to free-floating nuclear material that is clearly foreign to the adjacent tissue environment. What this means practically, a large dramatic herniation on MRI is not automatically a surgical emergency. It may represent the presentation most likely to resolve with conservative management, provided the neurological red flags that change the picture are absent. What physiotherapy does during this biological recovery window is critically important and makes the difference between a good outcome and a poor one. First, it manages your symptoms during the months the resorption is occurring, keeping you mobile, managing pain without relying exclusively on medication, and preventing the profound secondary deconditioning that turns a temporary disc problem into a chronic functional impairment. Second, it addresses the movement and loading factors that contributed to the herniation in the first place. The postural habits, the movement patterns, the muscle imbalances, the load management deficits that made your spine vulnerable. Without this second component, natural history improvement leaves you with a healed disc but an unchanged spine. The same vulnerability exposed to the same stresses, setting up the next episode. Recurrence rates are substantially lower in patients who complete a full rehabilitation program compared to those who recover through passive means alone. The natural history resolves the episode, but the rehabilitation changes the underlying conditions that made it possible. For chronic lower back pain present for more than 3 months, the evidence for physiotherapy as the primary treatment is equally strong and arguably more clinically important to understand, because surgery is more commonly discussed for this group. A comprehensive active physiotherapy program, progressive exercise-based rehabilitation, not passive modalities, consistently demonstrates better long-term outcomes than surgery for non-specific chronic lower back pain in the clinical literature. The critical caveat: when surgery is clearly the right choice, surgery is urgently indicated for progressive neurological deficit, worsening leg weakness that is measurably advancing, foot drop affecting walking mechanics, or any change in bladder or bowel function. These indicate nerve compression causing or risking irreversible neurological damage that requires prompt decompression. Most people considering surgery have not yet completed a treatment course that meets that standard. The link in the description provides a comprehensive breakdown of back pain treatment options in Malaysia, including what a complete physiotherapy program actually involves and how it compares to surgical intervention for each major condition type. Read it carefully and in full before making any treatment decision.